that we are going to discuss today is on bone tumors. So coming on to the classification, a basic classification of what is on bone tumors. It is based on the WHO classification, and for benign tumors we have the Anakin classification. They usually mainly occur over the metastasis, which is a common source, being in breast in females and prostate in males. Few important in these are under the cartilaginous. In benign, it is the osteochondroma and the chondroblastoma, whereas in malignant, it is the chondrosarcoma. Under osseous, it will be benign, which is osteoma and osteoid osteoma. And malignant, it will be osteosarcoma. Coming under fibrous, under benign it is non-ossifying fibroma, and malignant fibrosarcoma. In cystic, under benign will be giant cell tumors, ABC, aneurysmal bone tumors, and under malignant is wrongly described here. Besides this, under miscellaneous, malignant ones will be chondroma. Only these are the few basic bone tumors that you need to know. Coming on to osteoid osteoma, it is the most common true bone tumor, in which it occurs in around 20 to 30 years old, mainly in males, in the diaphragmal area of the tibia or the femur. Mainly occurs as a cortical lesion, but can be intramedullary, subperiosteal, and intraarticular. Clinical features which is common in most of them is pain. In this case, pain will be increased at night, mainly which occurs due to increased prostaglandins, cyclogenase, and is reduced by salicylates like aspirin and NSAIDs. The main common investigation here is an X-ray which we do, in which it shows radiolucent nidus present. यहाँ पे एक बार अटेंडेंस देंगे, बट हम लोग रजिस्टर में एंट्री नहीं करेंगे अटेंडेंस का. नीचे यूजीसीआर से वापस वो लोग रीचेक करेंगे अटेंडेंस और फिर वो भेज देंगे. ठीक है, तो इसके बाद यूजीसीआर में चले जाओ, वहाँ से अटेंडेंस वापस रीचेक करके फिर हमारे पास आ जाएगा. फिर हम इसमें अटेंडेंस रजिस्टर पे लगा देंगे. जो लेट है उनका एब्सेंट ही रहेगा. So in this case, the X-ray shows a radiolucent nidus present with a central region of mineralization with thick rim of dense sclerotic in which bones are surrounded. This is an X-ray. I'll show it to you later. CT scan is an investigation of choice. क्या हुआ, कोई डाउट है क्या? In which usually there is in 1.5 centimeters of no biopsy is required here. This is non-malignant, and the treatment here is basic. NSAIDs are given. Healing in the lesion occurs in around 3 to 4 years. If required, surgical excision, we surgically excise the entire nidus by a burr. We can also perform a percutaneous guided CT radiofrequency ablation of lesion where the nidus is burned in these cases. As you can see here, this is an X-ray, and this is the nidus. The small black structure that is seen here in the center is the nidus. This is the main cause of this tumor. So we take that out and it prevents other further spread of the tumor. Giant cell tumor, commonly asked in your maximum all your final exam papers. So this is a locally aggressive tumor. It is a benign tumor, but it is aggressive in nature, composed of giant cells. Last bench. क्या हुआ? Which are non-malignant. Second. It occurs in 20 to 40 years, and it is maximum at 30 years in females. Mostly occurs in females at the epiphysio-metaphyseal junction. It is commonly seen at the distal end of the femur, proximal end of the tibia, and distal end of the radius. The clinical features here are pain is progressive along with the swelling, and on palpating this, we hear a eggshell crackling sound on tapping the lesion. This is an important point. If you write it in the exam, see that you underline this point, eggshell cracking sound. So this is a giant cell tumor, X-ray of a giant cell tumor seen in the proximal tibia, in which you can see ground glass appearance type. So on investigations, it is an eccentric expansile lytic lesion which covers the subchondral bone. As you can see here, it is like a soap bubble appearance. Also underline this point, soap bubble appearance. It is covered by a thin shell of reactive bone that may break the cortex. The outer part of the bone is called the cortex. This is the outer part. It may break the cortex or may not break the cortex. MRI images show extent of bone lesion and soft tissue are dark on, this is not important, MRI findings. Microscopically, you can see multinucleated in a sea of mononuclear stromal cells, and there is meiotic activity or neoplastic components of the tumor. It has a Campanacci grading, in which in grade 1, it is the latent phase, grade 2, active phase, and grade 3, aggressive phase. Here the treatment is, we perform extended curettage, we remove the entire segment, after which, since after removing all the entire segments, there will be an entire gap that is seen here. Bone gap will be present, so in this place we apply bone cement. Excision of the bone tumor with other arthroplasty reconstruction can also be done. If required, wide excision with joint reconstruction may be needed. In medical treatment, we can give denosumab or bisphosphonates. And if also required to prevent further extension, we can give radiotherapy and chemotherapy. Osteosarcoma, it is another important question. I have covered only important topics in bone tumors, which are asked previously in your exam, and only important points, not emphasizing on everything, only a few points. Osteosarcoma is a highly malignant tumor in which osteoid production by the tumor cells occur. You can see from this side. Second most common primary malignant tumor of bone, and it is the most common non-hematological primary malignancy of the bone. It occurs in distal femur, proximal tibia, and proximal humerus. Why does it mean all these tumors mainly occur in these places? Because this is junction and there is a hairpin structure that is seen at these places. So all the blood supply at the end of the day accumulates at this place. So based on the epidemiology, we have a bimodal age distribution. It is seen in primary cases, it is seen at 20 years. At secondary cases, 40 years. More commonly seen in males. And the associated conditions may be Rathmund-Thompson syndrome, Leffermini syndrome, and retinoblastoma. Clinical features again: pain, swelling, restricted range of motion, and it will also be painful. There will be night pains. Night pains as in once the patient is asleep. Once the patient is asleep, the patient will have to wake up again because of pain. The skin will be shiny, warm, tender, and poorly demarcated. The regional lymph nodes will be enlarged, and neurovascular structures is compressed. The investigations here: X-ray, in which irregular destruction will be there, cortex will be eroded, and periosteal reaction will be seen. There will also be a Codman's triangle, something important, Codman's triangle, and sundry appearance to be underlined. Serum alkaline phosphatase will be raised here. We can get an MRI done, a biopsy, fine needle aspiration cytology can be done, or core needle biopsy can be done. And histology markers can also be done in these cases. This is an X-ray in which you can see periosteal growth is increased. So this periosteal growth forms the Codman's triangle. If an X-ray is asked to be read to you, these tumors are commonly can be understood because of this is the sundry appearance, in which you can see these are like rays going outside. So if they ask you what is this tumor of sundry appearance, hope you answer it. We can perform chemotherapy, in which the drugs given here may be methotrexate, cisplatin, doxorubicin, and vincristine. Protocols: T10 or BCD can be given, bleomycin, cyclophosphamide, and doxorubicin. Neoadjuvant chemotherapy can also be given to shrink the tumor. In surgical management, we perform a wide excision with reconstruction using prosthesis. This is the prosthesis, megaprosthesis, also known as do not disturb. In which we take a safe margin of around more than 1 centimeters. So after the tumor is removed, we remove this tumor. If this is the tumor here in this case, we remove around more than 1 centimeter. We send it to the lab. At that very moment, a frozen section is sent to the lab. It is tested. We get the result. We wait until the result. Until then, the patient is kept open on the surgery table. And after they give a clearance that the margins are clear, we go ahead in performing megaprosthesis or closing the patient. So in these cases, massive allografts and megaprosthesis may be required. Limb salvage surgery should be done when possible. As much as possible, we try to save the limb. Arthrodesis or joint replacement can be done as required, and post-op chemotherapy is given for 6 months. This is the MRI image, this is the X-ray image, this is the MRI image, this is the clinical photograph, and this is the megaprosthesis that is used in these cases. So much of the tumor needed to be removed from the proximal femur to the mid-shaft level of the tibia, after which this megaprosthesis was applied. An entire knee joint replacement was done, in which you can see in the X-ray and the clinical photograph. So coming on to Ewing sarcoma, in which this is the most common hematological primary malignancy of bone, mostly commonly seen in 10 years of age, and mostly in males, is Ewing sarcoma, the sites being femur diaphysis, pelvis, humerus, tibia, and flat bones. Here in these cases, the main cause can be translocation in chromosome 11 and 22. The clinical features here is pain, intermittent fever, local temperature rise, and tenderness. Needle aspirate may show pus. The investigations here is CRP, ESR, leukocytes will be raised. Patient will have anemia and LDH is high. X-ray will show permeative lytic lesions, moth-eaten appearance in diaphysis to be underlined. Lamellated periosteal reaction or onion peel appearance again to be underlined. MC2 gene detection, MRI to know the extent is there, And on histology, small round blue cells are seen. This again, here you can see a Codman's triangle is seen in these cases. In these cases, a moth-eaten appearance pattern is seen here, in which permeative destruction of the bone due to multiple lytic lesions. Here you can see in this an onion peel appearance, in which laminations of the periosteal layers are seen here. You can see over here and this. So treatment again here is vincristine, doxorubicin, cyclophosphamide, and actinomycin D. The tumor melts on radiotherapy and surgery after chemotherapy if indicated. ECT, extracorporeal therapy, irradiation when lesion is large and limb salvage is needed. So coming on to a last topic, in which bone cysts. So bone cysts is mainly a cavity in the bone, various types, in which simple bone cyst can be there and aneurysmal bone cyst can be there. These are benign in nature, and a defect in the growth plate development due to venous obstruction can occur. Pressure changes lead to cyst formation. Cyst wall is lined by thin fibrous membrane and straw colored serous fluid. Clinical features: 4 to 10 years old, and can occur up till 20, but 4 to 10 years is more common. More commonly seen in males. The common site being proximal humerus metaphysis, distal femur, and proximal tibia. If you don't remember anything, at least write these common sites. Often asymptomatic until the fracture occurs, and we perform an X-ray. So in the X-ray we see an eccentric. What is eccentric? What is centric? Centric will be in the center. Eccentric around, just besides that. Multiloculated, in which the periosteum is elevated. Central lesion, symmetrically expansile and does not cross the physis. In other cases, most of the tumors cross the physis. In these cases, it does not cross the physis. On MRI, we see interceptations and double density fluid levels. On the X-ray also, we can see a trapdoor sign or a fallen leaf fragment sign. This is important to be underlined. So this is the trapdoor, in which you can see on the X-ray. This is a trapdoor formation. Here you can see the trapdoor. Also, it can be called a fallen leaf sign, in which in between the tumor you can see a bone fragment. This is the trapdoor clinical image. That's how it got its name. So coming on to management, we can perform an aspiration and corticosteroid injection can be given, which is repeated over time. Curettage and bone grafting, along with extended curettage with adjuvants like liquid nitrogen phenol can be done if required. Extended can be done. Intralesional calcitonin or polyvinyl alcohol MPS injection can be given, and if in some cases embolization of the aneurysmal bone cyst can be done. What is the difference between simple bone cyst and aneurysmal bone cyst? Simple bone cyst, unicameral, occurs near the physis in children, and it has a slow course. Whereas ABC, it is blood-filled, rapid course, expansile, and centric with septations. This X-ray is always kept in your practical exam. This X-ray, similar to this, a proximal humerus X-ray, in which you can see these septations. So if this X-ray is, or to you, it is ABC, aneurysmal bone cyst.